Good morning. This is Dr. Rutledge, and I'm going to talk to you about big new things, which are actually little. All right, so let me share my screen. So we're going to be talking about the mini gastric bypass 2. No staples, less than 30 minutes, same-day surgery, 1/2 the cost, and extremely effective. And it may reverse diabetes in a large number of patients. So we are extremely excited to bring this forward. We're doing it in India and Mexico, the United States. So big times for us. We're very, very excited. So the MGB2 is faster and safer and better. What exactly is it? Well, it's the old MGB plus gastric plication. And we'll talk a little bit about that to explain it, but it's really simple. It basically, in the old days, the MGB, we would staple up the stomach, and there's bleeding and risks of leaks and all kinds of dangerous outcomes. And it takes time, and it's very expensive. The staples cost a fortune, almost as much as the surgery. So, but this is the new same old MGB, but it's shorter and safer and faster and much less expensive. So we hope you'll join us to participate in that. Okay, we want to talk about the endoscopic gastric plication. Okay, and there are a bunch of other names for it, but that's what I guess we use that plus a couple of others. And what can we learn from the endoscopic plication? Well, they took like your stomach and then they put stitches in it, but not from the outside, from the inside. So they pass an endoscope inside, and your big stomach gets small and you can't eat so much and you lose weight. Okay, they've had troubles with it, but now they got it pretty much straightened out. Okay, so here it is. The liquids run through and some of the food sticks up here. Storage and mixing. So this is what happens. It's the stomach stores and mixes food with gastric juices. Okay, that all still happens. Digestion breaks it down. Absorption then absorbs some things, and it controls food being kind of squeezed out into the rest of the gut. So the main thing that plication of the stomach does is it interferes with storage. And so let's see what would happen if you interfere with storage. Here's some examples. This is a gastric plication, and just for what we're going to talk about later, this is an MGB2. And I hope that looks similar. It does to me. This shows a plicated stomach. It's not stapled or anything like that. It's just plicated, just like this, except bigger and more powerful, a bunch of other things because of the way they're forced to do it through an endoscope. Okay, both of these do the same thing. And they do the same thing as part 1 of an MGB. Okay, but this is the MGB2 now. All right, so we have lots to explain to you. I'm sure you're all restless. What's a gastric plication? It's a medical procedure involves surgically folding and suturing the stomach to reduce the stomach's overall size. And this helps lose weight because you feel full. There's not enough room in there. You can't put as much in. It's that simple. It's just that simple. Here's a plication looking from the outside in, and they pull all this in and pull it in instead. So it reduces the stomach size. And it's been shown now for a couple of years, it works pretty well. You lose weight. Not as good as a MGB, but it's pretty good. So endoscopic, inserted through the mouth, that's this. They plicate, they have a little suture on here, they put those in, and takes 30 to 60 minutes. That's pretty cool. Except, it works okay, but not great. Okay, so introduction to the endoscopic gastric plication, all right? So it's a less invasive alternative to the traditional open bariatric surgery. Yep, it reduces the size of the stomach. Yep, and a lot of benefits, because if you can't eat as much, your diabetes and other things get better. Okay, so here's a study, 15% weight loss. Okay, that's pretty good. And up to even 18 to 24 months, 17%. They do tend to come back, but it works pretty well. And this is a study in 2024. There have been some severe side effects, but not too many. And again, here's some stomachs that have been plicated. It's not really pretty, but not bad. Okay, all plicated stomachs, and they look narrow. Now, what about the MGB2? Well, we know what the MGB is. It's a gastrojejunostomy, also called a Billroth 2. Plus, we narrow the stomach by stapling. That's the old MG. The MGB2 is we plicate the stomach instead of stapling it. It's that simple. Nothing new. It's the MGB bypass 2, gastric plication plus the Billroth 2. Exactly the same as before, but faster, shorter, safer, and equally powerful. Here is an MGB2. Look how tiny that stomach is. I mean, you're gonna lose weight. So here, just those who don't know, this is the esophagus. This is the new pouch. Here's the gastrojejunostomy where we connect, not where it should connect up here, but downstream. So that means you don't get as much digestion. You have trouble digesting fat and sugary foods. So there's a lot of benefits for that we can talk about later. Again, same thing, same thing, same thing. Okay, now why not just do the MGB? Well, there are deadly complications and dangerous complications. And here is the most common complications from one study. And basically leaks occurred at 2%. Well, that's horrible. Bleeding up to 20%. The staples are good, but when they close, they need to pinch and compress the intestine, the stomach wall. And if they don't, if they go too deep, they fall apart and then you get a leak. And if they don't go deep enough, then you get bleeding. So that's 2 to 20%. Can't stand it. So 8 simple rules, MGB2 equals the MGB. So simple philosophy of the MGB and now the MGB2. So number 1, the MGB removes the reservoir function of the stomach. This great big stomach gets small because we use a stapler and a razor blade. And then number 2 is we stay away from the EG junction. Roux-en-Y doctors are busy going up there, and sleeve doctors go up there, and it's potentially deadly. Not often, but sometimes. We don't dissect near the esophagus, the spleen, or the short gastrics. We make a much longer gastric pouch, which is better for reflux. We decrease ischemia and foreign body to the lateral gastric wall. And then part 2, it's a very simple philosophy. We increase the size of the gastrojejunostomy for better dumping and more powerful effect on eating fatty, greasy, or sugary foods. We decrease or eliminate a staple line. So, there's no staple lines to leak or bleed or perforate. It's easily revised or reversed. So, and you can tailor it to each person. So a thin diabetic can have this. You don't have to be overweight because we can do a little MGB2 in a very short period of time and potentially reverse diabetes. And that's what we're talking about today. So it's powerful, it's short, it's simple, it's low cost. It has decreased risk of bleeding and leaks, which are deadly, dangerous complications. No staples, 30 minutes, same day surgery, go home the same day. Risk of bleeding leaks are cut. I don't know, we haven't had it. Resource utilization, costs of staples, much less, and the risks of reflux and treatment of diabetes. All right, so let's go through and see how we do in MGB2. So stand here. Here's the stomach, the abdomen, and you look in here. Up here is the liver and the diaphragm and the head of the patient. Here's the tube coming down. This is what's called the lesser curvature. And that's the greater curvature of the stomach. And so the new pouch is that much longer, so there's much less reflux. We find the ligament of Treitz, that's where the small bowel comes through in the gut, bring it up, and we hook the two together. And we staple them and sew them up. And so now that's together. That usually takes 10 minutes, maybe 15. Now we're almost done. All we do now is we're going to do the plication. So we start at the top and we stitch, and then we stitch the antrum, and that's done. This is the way out, this is the way in, and that's the end of the story. There's the plicated stomach. So now the stomach is small, about the size of a big cigar, like you saw in the X-ray. There it is again, stomach, incoming, outgoing, and the antrum here hasn't been plicated yet, but it will be in a moment. Same thing again, incoming, outcoming. This is the stomach pouch now all stitched up like a girdle. So distal greater curvature, gastrojejunostomy, longer gastric pouch, better blood supply, less reflux, longer distance from the esophagus. So Roux-en-Y puts their anastomosis up here, very dangerous, you get reflux. Here is where some non-MGBers do it, that's bad. Here is where the MGB is, which is pretty good, but it's even better with the MGB2. Here's the old spot. And you see, this is old, and way down here is new. So it's much longer tube, which has many advantages. And we do an anterior plication, and it's minimal bleeding and leaks, cuts costs, decreases risk, and it's useful in thin diabetics. Presumably, we believe we have a high rate, according to published literature, of reversing diabetes. Here's this X-rays, and that's the end. Thank you all very much. I hope you found that interesting. And stop sharing. We'll see you all soon.